How's the volume? I'm a little bit raspy today, so I'll do my best to enunciate. As Nigel mentioned, my name is Alex Kent. I am a Master of Public Health student, and I chose the thesis route. So I took a bit of a different course. I started in 2014 after completing my Bachelor of Arts in Health and Community Services. So needless to say, I have quite a long-standing affiliation with PHSP, and it's been wonderful. Today I'm going to share with you some of the findings from my thesis and a little bit of the journey as well. My thesis, I focus on Indigenous health equity as a priority in BC's public health system. I partnered with Equity Lens in Public Health Research Program to do a pilot case study of one of the health authorities, which will remain unnamed. I always like to start with an acknowledgement of the territories, which today would be the lands and waters of the Wasanich and Lekwungen-speaking peoples. I also like to acknowledge the Stalo and St'alis territories, which is where I was born and raised. And if I can take a moment to thank my loved ones and my family and my colleagues for the amazing support they gave me throughout my studies. So for those of you in the MPH program, particularly the full-time ones, this will look familiar. This is our program plan. I did mostly the same courses, mostly the same plan, a little bit modified to accommodate my thesis because I did my best. I was trying to complete it in 2 years. It ended up being 3 years, but I was working on it all throughout from the beginning. And the faculty and department was very supportive in helping me along the way by letting me do things such as writing certain chapters during some of the core courses. For instance, PHSP 504, I did a policy environmental scan. I worked on my scoping review and my methods chapter in Kathy's class. And I used the practicum to do some stakeholder engagement, and I was able to present some preliminary findings to stakeholders throughout BC's public health system, which was a fantastic experience for me. And then I added on a year. I did a lot of thinking about the significance of my findings and the implications for public health practice. Now I've been finishing up with some revisions, and I'll defend this summer before I start my PhD in September. So my research objectives are threefold. First, I aim to conceptualize relational environments within the public health system using a tree model, which I will go into detail in the next slide. And I aim to identify barriers and facilitators to health equity for Indigenous peoples in BC. Finally, I'm trying to analyze the uptake and implementation of Indigenous health equity as a priority in BC health authorities. This is the framework which I referenced. It's an adaptation of the tree model, which you may be familiar with. It was developed by Dr. Charlotte Lopi. We've renamed it Hippe Relational Environments. Hippe is a Halkominum term for Western red cedar. So in the original tree model, Charlotte used proximal, intermediate, and distal determinants of health in this framework to really conceptualize and map how various determinants of health influence Indigenous peoples in particular. We've taken this and modified it to frame relational environments, which are the physical and theoretical settings where health equity is manifested in BC's public health system. And the three levels that we've defined are the STEM environments, which are the most tangible and direct effects on health equity. Those may be interpersonal relationships, or access to health services and infrastructure, or symbolic representation of Indigenous peoples. The core environment is a little more indirect, but it sets the context through which the STEM environments operate and function. So while I was coding, I was looking for communities, institutions, systems, and policies as manifestations of health equity. And finally, the root environment. These are often unseen, but have a profound effect. So some people refer to these as the upstream factors. And we're looking at cultural, social, historical, and political factors that really influence health and health equity. In the last few slides, I've tried to present a bit of a snapshot of some of my analyses. There's absolutely no way I can finish this in 5 minutes, so I'm hoping that if I can provide an introduction, maybe I'll pique your interest in one of these areas and you can ask me questions further. This table is, it demonstrates some of the barriers and facilitators to health equity for Indigenous peoples, as referenced in the data. The color and the size of each box shows their frequency and the number of references that came up in interviews and focus groups with senior executives and frontline workers, as well as core documents in the health authorities' plans. We'll see here that partnerships, accessibility, collaboration were really strong keywords when talking about barriers and facilitators to health equity for Indigenous peoples. We also see cultural safety and cultural safety training coming up, but what I've found most interesting is on the far end, the less cited codes are barriers such as colonialism and racism, and facilitators such as self-determination and cultural connectivity. Again, I want to emphasize that this doesn't necessarily represent their significance as determinants of Indigenous health equity, but rather this is the number of references in the data. So it could indicate perhaps a level of discomfort with discussing these important determinants. And this is the same table, but in this instance, the colors of the same barriers and facilitators are representing where they're located in that HIPAA relational environments framework. The yellow are the STEM environments, orange core environments, and red root environments. So again, although the root environments are really significant in Indigenous health and models of wellness, they're not being discussed as frequently within the health authority. I included this slide to show that these relational environments are not operating in isolation. They're working together to frame and set the context for health equity. A key element of my analysis was discourse analysis, particularly in relation to how Indigenous peoples are positioned as a priority population. We see here that in the Health Authority's strategic plan, they're grouped together as a high needs population. High needs also tends to be referred to in terms of high risk, vulnerable, and sometimes high cost. And we see other groups such as those in rural and remote areas, homeless, chronically ill, persons with disabilities, frail elderly. And we can see how this would be a problematic discourse for Indigenous peoples in particular, particularly because Indigenous identity or indigeneity can be seen under this discourse as a risk factor, when instead we want to frame it as a protective factor. And it also ignores or perhaps downplays some of the systemic and structural issues that are creating injustice and inequity for Indigenous peoples, and instead looks at indigeneity as the issue. I have included some quotes here. I realize I'm down to 1 minute, but this is my last slide. So I'm going to jump to the ones that I find most revealing. So this is how Indigenous health equity is prioritized in the health system at the core level in particular. So we see that a senior executive is saying that, yes, in fact, Indigenous health equity is a key priority. And in the strategic plan, it outlines some goals or some avenues through which it is being prioritized and implemented. For instance, engaging and working collaboratively with Indigenous communities, establishing an Aboriginal Health Council, and implementing cultural safety training. But if we look further into some of our transcripts from interviews, we see that people are suggesting that, in fact, the organizational structure has completely crippled the ability to work collaboratively and innovatively at the community level. And this person is actually embarrassed to write final reports that say that we're going through with some of these proposed actions of working collaboratively. So I have other examples of how prioritizing Indigenous health equity can be problematized at not only the core level, but also the stem and the root. But this is just one example from my analysis. So at this point, I will move into questions. And thank you for your time and for sitting through the entire day.
Thank you, Alex.
Thanks,
you've given us a lot to think about. There must be some questions.
I'm curious, how many interviews did you do?
Okay, so this is a huge program of research. Equity Lens in Public Health, ELF, is a 5-year program of research, and they did interviews and focus groups in all the health authorities. They did 2 rounds of data collection. My pilot case study is, I did both phase 1 and phase 2 for one health authority, and I did both senior executives and frontline, which was a total of, I ended up focusing for my thesis analysis on just phase 1 senior executives, which ended up being 11. So if you can think that that's just like one tiny piece of the whole thing, I think that I have like 35 altogether in my in vivo file, but that's just one health authority. So there's a lot of data. And each of the interviews and focus groups were about 1 hour and 15 to 1 hour and a half. And then we're looking at full strategic plans. Yeah, thank you.
That's good. I want that exercise at the end of the day.
Hi, I was just curious in terms of the strategic plan that you were speaking of. Is that with regards to the Ministry of Health, or are you speaking more on the First Nations Health Authority?
Neither. So this is one of the regional health authorities. Although we did take into consideration both the ministry and FNHA's documents as context for each of the health authorities, because we recognize that the ministry is setting priorities, and that's actually come up as a key influence. And each of the health authorities are also have partnership accords with FNHA and are getting strategic direction from FNHA. However, in the data set, this is the strategic plan, the 5-year plan, and the goals and vision for that particular health authority.
Okay,
Thanks for the question.
So Alex, where are you going to be doing your PhD?
Oh, at SFU.
The other place then, okay.
Yeah.
Are you sure you're not already writing your dissertation?
It feels like it. It feels like it. And actually, that's a good point. I had these huge, ambitious goals at the beginning. I was thinking that I would not only do like one health authority, which I ended up doing like a segment of the health authority. I was like, oh, I'll do all the health authorities, do a provincial level analysis. And I think as I kept going, I realized I had to scale this down. You know, this is my master's thesis. It could end up being 5 years if I'm trying to do it all. But because I was able to work with such an incredible team, both Elf and Charlotte, it's been a really supportive environment to take this pilot case study, present it back to our stakeholders, and see what is the potential moving forward to expand upon that research. Thanks, Glenn.
Well, thank you very much. Well, before I hand over to this microphone to Catherine to wrap up, I just wanted to thank the 4 speakers for excellent presentations and being perfectly on time, so I didn't have to yank you off the stage or anything like that. And I have had a request from Kamel to make sure that you take all your garbage out with you when you leave the room, so nothing's left in here. So again, thank you very much.